The views expressed in the following podcast are not necessarily the views of the United States Air Force or the Air Force Reserve, but rather the perspectives of the individual speakers. No endorsement of any particular person, business, or interest is ever intended.
Greetings, everyone. Welcome back to Ready, Set, Airlift. I'm your host, Julian Hernandez with the 433rd Airlift Wing Public Affairs Office. So if you're wondering why we didn't get an episode out to you last month, today we're discussing the reason why. During the end of March, beginning of April, our team was on the road covering the amazing work of the 433rd Medical Group as part of the Lesser Antilles Medical Assistance Team mission, or LAMAT for short. This mission was a global health engagement that not only helped our airmen hone their skills and increase readiness, but also positively impacted the lives of thousands of people across 4 partner nations. On today's episode, 2 key players in LAMAT 25 joined me to break down how powerful this mission was and how it benefited the 433rd Medical Group. All right, Colonel Matt Bershinsky, commander of the 433rd Medical Group, and Major Mohamed Osman, 433rd Medical Squadron neurocritical care physician, join me both here on this episode of Ready, Set, Airlift that is going to be focusing entirely on LAMAT, the Lesser Antilles Medical Assistance Team. Gentlemen, thank you so much for being with me today.
Hey, thanks for having us.
Yeah, thank you.
I'm really excited to talk shop about LAMAT. Colonel Bershinsky, I'd like to start with you just as the commander overall of LAMAT. Tell us how that looked from your view.
Oh, thanks for having us here, Julian. LAMAT is a mission that's really run by U.S. Southern Command. It was specifically given to Air Forces Southern out of David Monthan to accomplish their goal of reaching out and connecting with partner nations through the U.S. Southcom AOR. There's 31 countries down there, so we had to narrow it down, and we settled on 4. What they really needed from the reserves was expertise. They needed people to come down and help execute this mission. So they reached out through AFRIC. This is the 3rd year in a row they've done this. It's steadily gotten bigger and more robust every year. But AFRIC SGX in particular was given the task of finding a unit that could handle the scope and scale of this proposed mission, and the 433rd is where the bulk of it settled. The idea behind this was that we would take U.S. medical forces and go to countries that are our partners and our allies in Southcom, integrate our medical people with their existing medical clinics and providers, and help to integrate our medical expertise and learn from them and how they operate in their environment while bringing our own level of skills and supplies and equipment to that location.
Fantastic. And speaking of that integration, Major Osman, you were there integrated with those host nation providers, working alongside them. Tell us about LAMAT from your perspective.
Yeah, thank you. LAMAT was a very unique experience. As somebody who works in the critical care field and especially critical care air transport, we are very used to bringing our mission with us and bringing the capability up to the level that we would expect in most tertiary care centers. Adapting that ability and being agile in adapting to a unique environment where there's some resource limitations, when there's some lack of certain equipment, certain institutional protocols, was very helpful and I think uniquely powerful in amplifying the agility of the Air Force warfighter. Being able to completely adapt our mission and adapt our capabilities to the environment and to the capabilities was significantly unique to that situation.
Historically, a lot of people call this a medical mission. And historically, a medical mission, especially in the military, has been we load everything up on a plane, we fly somewhere, we drop the gate, we set up a tent, and we provide U.S.-level health care out of a tent for a week or 2. And then when it's done, we roll up the flaps, throw it back on the plane, and we disappear. And that was not the goal of LAMAT. The goal of LAMAT was to more closely integrate with the host nation, but also, even more importantly, was to allow our people the opportunity to learn what it looks like to provide medical care in a country where we don't have our own facilities and resources. If we look at the next fight, the high-level engagement, the next strategic challenge that we look at, we keep talking about how that might involve us going to an island somewhere that doesn't have good communications, it doesn't have evac capability, it doesn't have a resupply, and we may be asked to do more with less in this environment. Guess what? Our contingency looks like their everyday operations in the countries that we went to. They're already very used to operating in a resource-constrained environment, and so that was really one of our main priorities, was getting our people that opportunity.
Yeah, no, it's impressive because talking with some of the providers and our members as they were working alongside the partners, in my case in St. Kitts, that was one of my questions to them is, what are you learning here? What's the experience that you're getting out of this? And I heard multiple times that like, hey, if we end up at a partner nation in any AOR in the world, like this gives us that experience of, okay, you're here, figure it out. And things aren't going to be the way that you plan them out. They're not going to have the things that you thought they were going to have. And you only brought a handful of things and now figure it out to deliver effective care. And I could say I really saw that happening in all the different areas that I got to visit.
Yeah, we saw an interesting and very rapid shift in the communication that was coming back at each location. Day one, we would get communication back saying, hey, we need this, we don't have this, can we get some of this? And my answer was across the board, nope, sorry about that. We can't get anything done to you. You're going to have to figure it out. And after about the second or third day of that, everybody's, I think we can still pull this off. We're not going to get exactly what we need, but we can still do what we need to do. And they started to get a lot more creative on the provision of healthcare.
Absolutely. I'm curious now that I have insight into the planning level of LAMAT and then other people who were just there as well. There was a way that I like dreamt of LAMAT. I had my imagination of what it was going to be like. And then I was actually there and it was different. Colonel Bershinsky, in your case, being intimately involved in the planning, how do you feel like your vision for what LAMAT was going to be versus how it turned out? What are some differences there, or how'd that turn out?
Yeah, my primary goal in this was for the last 20 years, we have had this deployment rotation that is very fixed. We know when we're going to go. We know what our spin-up cycle is going to be. We get people aboard a charter aircraft. We fly them to a facility that has a secure perimeter. It has a really nice airstrip. It has a U.S.-level medical clinic with immediate evac capability and probably a Starbucks and a Pizza Hut right next door. And so that's been our deployment for literally going on 20 years. What I really wanted, my number one priority out of this whole thing, was I wanted our teams to have to gather together, go through the hurdles required to get out the door, move out as a unit, and establish themselves in an unfamiliar AOR with limited supply and adapt to that environment on the ground with a lot of things being unknown until you're actually there eyes on. Our ADVON was very small on purpose, or our site survey was, our PDSS was very small on purpose. We came back with some of the general groundwork, but then I came back and I briefed our squadron commanders on each of their locations and what the goals were for this mission. And just for dramatic effect, I literally pushed my notebook across the table to them. I said, this is your mission now. This is your location. This is your country. Make it happen. And like a very proud dad, they took it and they ran with it, and I couldn't be more happy with how they each grabbed onto it and just made it happen with various challenges among the locations. So that was one thing we really hoped, is that people would rise to that level. They certainly did. The second part was dealing with, again, the lack of supply, the lack of communication, those sort of things. And in healthcare in particular, on the civilian side, we work under a inordinate amount of rules and regulations that stipulate every single aspect of what we do, to how long we leave an IV in one site on a patient, to how medications are controlled from their point of origin all the way until they're given to the patient with an endless number of quality checks along the way. It works when you have our healthcare delivery system back here, although it's still pretty onerous. But when you go down to a place that doesn't do that, it takes a big mindset shift for people to get used to taking ownership of the provision of care to that patient, no matter what else is going on around them. And again, everybody just rose to the occasion, got a little uncomfortable with what they were doing, and then figured out they could do it anyway.
Major Osman, you got to go down there and execute on that commander's intent that Colonel Bershinsky just laid out. How did that feel from where you were working?
Yeah, no, I think Colonel Bershinsky stated it very expertly, that I think it was unique for a lot of us who are used to having very set expectations. When I go into the hospital, I know what capabilities I will have. I know what our requirements are for certain time hacks, for certain parameters that we're sticking to provide that patient care. I know what medications we have at pharmacy. I know what to expect from every aspect of the care, but adapting that to an unknown environment where, all right, first of all, as soon as I get there, what are our capabilities? What are the medications that we have? What are the diagnostic capabilities? And then changing that mind shift from the first couple of days where you're like, we don't have this, we don't have this, we don't have this, to, all right, how do we provide that care while not having this? What are our workarounds? And you will be surprised as time goes on and you adapt that different mindset to how do we provide the care with what we have can significantly change, and people rise to that occasion, rise to that challenge to be able to provide the same level of care or as close to that same level of care as possible. Where if we don't have a specific device, that maybe we don't have an infusion pump that can calculate doses for you, we're going to do the math ourselves, or we're going to go back to the basics. We're going to actually, medicine was being done quite well before infusion pumps were a thing, right? So how do we do that with the same level? And even finding that there are a lot of things that we can do that do not require the comfort, luxuries, and capabilities of tertiary care centers and U.S. level hospitals. With very limited things, we can actually provide a lot of care. And I think integrating with the host nation, working with their physicians, with their medical staff, sharing that knowledge and bridging that gap of this is what we do because this is what we're capable of with our resources, to upgrading a lot of that mindset on both ends, where we can do that with the same level of resources, or we can provide that workaround so that we can provide that care. I think that was a unique change that I noticed from my expectations going in to how things evolved over the time there.
Can I draw you out a little bit on like a specific workaround or memorable like knowledge exchange from your time down there?
One of the unique things that I noticed when we got there is that in the emergency room at the hospital, there was no stroke protocol or stroke care that was being administered. And a lot of the questions rose, why don't we do that? And having discussions and education sessions and communicating with the team there, we're able to actually find out we have a CT scanner and we also have the medication, but we did not connect both together, that we actually have all the capability to provide that level of care, and all we need to do is to actually set that protocol or set that workflow. Working with the team there, we were able to provide them with some protocols and some knowledge base so that they can actually increase the utilization of the resources that they have to provide better care. That was, I think, something that was very helpful.
I'm going to use two examples of our people getting out of their comfort zone down there. We have a senior in Verdine over at the AMDS who works in our record rooms. He is a patient records technician. He's also as strong as an ox. He can lift the world. And so we put him on the Advon because we had literally $1 million of medical supplies shipped down there that needed to be inventoried, sorted, delivered, stacked, you name it. He was the guy for the job. He accomplished that pretty quickly. And by the time the patient care really started to roll around, he'd accomplished most of what he needed to on that side. But they were very short over in the dental clinic. And they said, hey, can you come help us out? He's, yes, I can. And next thing, he's in there, rubber gloves on, helping the dentist out, provision of care, something way outside of his lane. That you talk about multi-capable airmen. When it comes to a medical concept, you're going to enlist the help of anybody that is willing and able, and he certainly rose to that occasion. The second example was down in Guyana. We brought an ophthalmology surgeon down there. They have a huge backlog of people with eyesight-threatening conditions and nobody to take care of them. Unfortunately, at the last minute, two of his team members had to back out, and he realized quickly, I can be here, but without a team, I'm nothing. And so our AGR administrator from the ASTS, Senior Master Sergeant Nagel, volunteered to go help the ophthalmologic surgeon. Over the course of 2 weeks, she worked 12 days in a row, logging 150-something hours of patient care time. She coordinated and scheduled 364 patients, and they performed over 80 vision-saving operations in 12 days. And she was in the middle of every single one. In the operating room, she kind of ran the show for that team and saved their eyesight. So again, this is an AGR who spends most of her time on CSS duties, but now she's saving eyesight. And so given those opportunities, you just never quite know how people can help the fight.
Absolutely. And LAMAT has generated some impressive data in the tens of thousands, correct me if I'm wrong, of readiness hours and training equivalency completed, thousands of patients that were treated across the 4 locations. And that data gives a qualitative edge to the story. But one of the impressive things, at least in St. Kitts, was a lot of people were talking about the lives that were touched, like the real people who are better off today thanks to the efforts of all the teams and where they went. And so I wanted to touch base. I know Major Osman, you and I were present for one story that kind of follows that of like lives that were touched. But yeah, I want to take the conversation in that direction, if you wouldn't mind sharing, Major Osman.
Definitely a unique case that I never, if you had asked me like before I went, would you ever see yourself taking care of a patient like that or helping take care of a patient like that, I would have never have guessed that. But being in a situation where, as Colonel Bershinsky mentioned, like the lines are blurred between what specialty you are and what kind of patients that you're usually comfortable taking care of. Sometimes you are the best one in the area to be able to provide certain help or certain support to a patient who otherwise would not have seen that. And we were faced with a patient who was very young and who was quite unfortunate, suffered significant traumatic injuries with traumatic brain injury as well. Helping the emergency room staff who did an outstanding job resuscitating that patient and maintaining their life and saving their life, guide their help and help them make decisions about certain aspects of that care that pertains to certain areas that we were having to adapt very different complex issues towards was very unique. I think it was probably 5 or 6 specialists in the room trying to piece everything together and put their minds together how to adapt all our backgrounds to that unique patient and how to safely get them the care that we can to get them to a situation where they can get advanced care was very unique. I think it was speaking to the multi-capable airmen aspect, to the agile combat employment, where just trying to adapt to a resource setting where we're not comfortable doing the same things that we were comfortable doing or we practice every day. Just seeing all the airmen providers get together and work hand in hand and kind of in a very closed loop, harmonious environment was unique. To see that get the care and to see it where the family can actually find confidence in service members and actually talk to them as if they're family members. So that was to me unique, where we felt that we actually touched the lives of actual patients that we otherwise would never have in a different situation. Yeah.
And being there as that story was developing was powerful, but then to hear it told and passed forward and to hear leaders of the host nation discussing it as they were talking about the impact of the mission really put it into perspective, like how important it is, that interaction with the real lives. And Colonel Bershinsky, at your level planning, I'm sure this is one of many stories of lives touched that hopefully made it up to the leadership so that you could hear these real stories of not just metrics, but people that are benefiting.
Yeah. And one of these, it's not a very specific patient story, but it's a win in my book, was that most of the countries that we go to don't have EMS. They don't have 911. You don't pick up the phone and call a number and professionals go roaring out and save lives on the ground. That just doesn't happen. If you're involved in a bad wreck, if you have a trauma, then the people that are around you will pick you up, throw you in their car and drive you to the nearest clinic. Some of the clinics have ambulances, but they are not staffed by EMS personnel. They'll have a driver and an attendant that will actually drive there, pick up the injured person or the sick person and bring them to the hospital. So our paradigm of EMS doesn't exist in these countries. Our TCCC program that we have developed and implemented here in the Air Force Reserve is a skill set that they love to have in these countries, and they have not gotten a lot of exposure to it. It's their civilian equivalents, pre-hospital trauma life support, our emergency medical technicians. Those sort of training programs are not very common in the countries that we were operating in. So one of the other things that we did is the entire time that we were there, we had the opportunity to share that knowledge. We had a team of Army Civil Affairs who came from country to country and taught TCCC. We had a Special Forces physician assistant from Southcom who came and brought his equipment and taught as well. And one of the great strengths about the reserves is that we don't do this every day, that we have civilian jobs, expertise that extends way beyond what in our day-to-day in the reserves. We had people who are emergency room physicians and nurses and paramedics, firefighters that also brought that skill set down there. And everywhere you look, they've got some people in a corner and they're sharing this knowledge. They would set up small simulations where people could work through some of these skills, these trauma assessments. They went through their ambulances and they went through their supplies and showed them how they might optimize some of this stuff. And so now when we roll home, those lessons that they brought, that expertise that they brought is not going away. They're using that every day down there. That's one of the bigger wins that we got out of this, is we can go down for 2 weeks and have an impact that's going to last into the future.
That was echoed by some of the host nation providers I had a chance to speak with, is that they were certainly grateful for having the expertise on hand during the time of LAMAT. But for them, the real win was having had that touch point with these experts and retaining that knowledge beyond the time that our members were present. So I think that was one of the parts where, sometimes with military missions, you hear the talking points and then you wonder, does that really trickle down to where the mission's happening? And in this case, 100%. The knowledge exchange, the building partnerships, that was the real deal based on my experiences talking to the folks in country, that it's what was going on, truly.
Yeah, to that point, exactly. I think one story that I remember is that there was the TCCC training that was being conducted to a lot of the emergency providers who provide pre-hospital care and bring the patients in. There was one of the emergency EMT equivalents there who was in the class, and they were taught a figure-of-8 bandage that is uniquely helpful in bandaging difficult to control wounds. And the next day from the class, they actually were tasked with picking up a patient who was a gunshot wound victim who had a neck wound, that they applied the figure-of-8 bandage to the patient and was able to effectively stop the bleeding and bring him into the hospital. That patient later was discharged from the ER, so they saved their life. And that was something that was unique to see, that the education was applied even within the same week to saving someone's life. And it makes you feel that at that point, yes, that benefit is going to multiply and expand over time.
Yes, so many powerful stories that came out of LAMAT, really, and I was surprised to find out in preparation for this mission, this is like only the second time I think it's been done recently.
Third time.
Third time.
The first year was a very small engagement. Last year, the 349th out of Travis took it and built it up significantly bigger. This year certainly set the standard for scope and scale, and every country we went to is very excited to have us back for LAMAT 26.
Yes. Yeah, the Prime Minister of St. Kitts and Nevis closed his address with that comment of, "We invite you and look forward to welcoming you back in 2026, which is a testament to the good work that our people were involved in down there. While we're on that subject, what's on the wish list for LAMAT 2026 from the 433rd Medical Group perspective?
Yeah, from our perspective, it's a multifaceted answer, because this mission required a whole lot of planning and a whole lot of money from the 433rd to make this happen. We pulled it off. Air Forces Southern is extremely pleased with how everything went. We accomplished the mission, went way above and beyond what they were hoping for out of this. If you look at our AFRGEN cycle, this is something that fits really well into that year 1 and year 2 prior to getting into the ready stage. From a big picture, I do want to see this experience or this opportunity shopped around among other African medical units. But the reservation on the side of AFSouth is that they don't want to have to reinvent the wheel every year. So we have to figure out a way to have some continuum of some people that have experienced this in the past, and then a rolling handoff where you have an experienced team who the next year is mentoring up a less experienced team, and then they step back and continue to roll that opportunity throughout. That will certainly ease the burden on the planning side. It'll ease the burden on the AFSouth side, but most importantly, we developed a lot of really close relationships while we were doing this. Relationships with our active duty and sister service counterparts, relationships with the providers and staff and patients on the ground in these countries. And to be able to continue that year after year, I think would only serve to enhance this mission. In an ideal world, we would take a core contingent of people who have this experience now. We would then build a team from other units and let them take over their location, and again, give a rolling handoff of this global health engagement down the road.
Major Osman, from your perspective, being one of the medical professionals down there, maybe what are some things that you think would have helped you from a provider level coming into it, right? Now that you've got that experience, what would you hand off to someone else? From your perspective, what would have been helpful to you?
Yeah, no, I think the same aspect, that being able to have that mentorship, that expectation, prepare you a little bit so that you're minimizing any time as soon as you arrive into providing that beneficial support, that beneficial training, that beneficial education, knowing what you're going to be faced with and what are the asks, the expectations. Also preparing the people on the ground there for, all right, how can we maximize the benefit, and the mutual collaboration would, I think, be significantly beneficial in future missions.
From talking about the future to the more immediate future, a mission like LAMAT, me personally, I was exhausted when I get back, and I'm sure I'm not the only one. And our folks were exposed to some serious situations down there. I think there was at least a few instances where members were involved in cases where, unfortunately, there was a loss of life at the end of the care just because of the situation. Now that the members are back, let's talk a little bit about some of the recovery side of the house, right? How are members processing, recovering, and recouping following such a big lift like this?
I come from an Army background, spent a bit of time in combat zones, and there was a practice where we would have an enemy combatant come in with wounds inflicted by U.S. service members. And the U.S. service members that were involved in that conflict would actually come into the clinic, and they would go look at that person that they had shot, and they would look at the wounds inflicted, and they would get that imprinted into their head, and the team would talk about it. They would shop it out in the open. They would say, yep, that was a good engagement. Rules of engagement were followed. You made excellent tactical decisions. Well done. And they would move on. And the fact that they were exposed to that trauma was a lot easier to deal with when it was a part of the mission and a part of the team. And I think in military and in healthcare settings, we tend to get away from that sometime, and we tend to take those traumatic events and hash them over and tend to keep reopening the same scabs over and over again instead of dealing with it all at the time, saying, yep, this stuff happens. Guess what? It's part of war. It's part of medicine, and let's move on with the mission. Our team did a remarkable job on that, where they discussed it the time that it happened, the day that it happened. They expressed their frustrations over what they could and couldn't fix at the time, and then everybody moved on and took care of the next hurt person. And I think that real-time dealing with that trauma does way more than 10 years of therapy down the road.
Major Osman, from your perspective, being back, any personal habits, processes that you went through to help you re-energize and recoup after LAMAT?
For me, the biggest thing was getting right back into it. My civilian job, I am fortunate and privileged to be able to care for a lot of critically ill patients. As Colonel Bershinsky mentioned, focusing on the next patient, because you can't afford to have that distraction. It is something that we should never take lightly, but any unprocessed feelings, emotions can significantly impact healthcare providers. And focusing on the next patient, making sure that you're giving them 100% of your attention, 100% of your focus, is going to be paramount, so that you make sure that you provide them with the best care that you can, and also making sure that you're not taking that home with you to your family, to your spouses and loved ones, and making sure that doesn't spill over, so that you're processing all these emotions and all these feelings in the appropriate time and in the appropriate manner, and then also seeking the help that you need if you can, if you do need it. But yeah, getting right back into it and taking care of the next patient has been, in my experience, one of my methods of recuperation.
Yeah, what's the old adage? Idle hands do the devil's work, or something to that effect. Sometimes having that engagement right after something like that is good to just force your mind to move on to the next thing. Absolutely. Coming back, something that was interesting to me is a lot of people said to me, like, oh, you guys were on vacation in the Caribbean for 2 weeks. I'm like, absolutely not. Like, we worked, at least for me, like I was working 12, 14-hour days. I'm sure people were working more than that, depending on their responsibilities and engagement. But I'm curious, did you guys have some maybe humorous off-the-cuff responses like that once you were back from folks of, oh, you guys were just down there doing whatever?
Yeah, it's all about ask the team in Guyana how much time they spent on the beach. Yeah, probably not a whole lot. No, we were actually truly blessed in that we had clean facilities. Again, coming from an Army background, I'm happy we weren't sleeping in tents out in the jungle.
To that. So, as an infantryman, I second that.
No question.
Former infantryman.
So they actually had hotel rooms. We had a few incidents of foodborne illnesses. Sorry to our major who got typhoid fever, but you know what? There is endemic disease where you go down there, and we were operating in places that were gorgeous. They have 5-star resorts. They have beautiful beaches. And you go out the gate and go 100 yards further, and people living in environments that can be very challenging economically for them to make a living, and steeped in a tradition of a very independent population. And the management of diseases, the economic development, those are all things that they're working on there. The healthcare facilities, again, they work every day to improve their position, but they're nowhere close to what we're used to. Again, a couple of the islands did have opportunities to get a half day off and actually go get a little sunburned, but most of what we saw was the inside of a non-air conditioned hospital. That was quite surprising that they're doing this when it's 92 degrees outside and 92% humidity, and the patients just lay there and sweat. It was definitely a beautiful area, but we weren't exactly living a resort life.
Yeah, no, most certainly. I think it was a very beautiful setting, and I think that was, for some of us, I think just to be able to have the privilege to go to work and take care of patients and see the scenery on the way there and on the way back, and in the evening just decompress. But I think going in, that was the mindset, is that we're going there to do a job. We're going there to take care of patients. And I think that mindset kind of stayed. And that mindset, early mornings, late evenings, taking care of patients, I think was the priority to do that. So,
boy, you talk about a culture that is some of the most warm, welcoming, engaging people. Everywhere we went down there, we made friends. And we would walk in and people would recognize us and come over to shake our hands and take pictures. And we all fell in love with the populations of the countries that we went to. That was one of the more rewarding things, was that long-term friendship. I have people message me on WhatsApp nearly every day from one of our LAMAT missions asking how things are up in snowy Colorado.
And it's interesting, my family background is Cuban, so there's a Caribbean island component to my upbringing and my cultural background. It was super cool to go to St. Kitts, a completely different cultural background, but still Caribbean flavor, and see the crossover. Things of, oh yeah, there's this type of food in Cuban cuisine, or there's these types of habits in Cuban culture generally. No, super amazing opportunity, not just to go down there and, as we've been talking about, like accomplish mission objectives, increase readiness, and have impact on real lives, but just learn and broaden our cultural horizons. I'll be honest, I don't know if I would have ever found my way to St. Kitts if it hadn't been through a mission like LAMAT. And talking about those bonds built too, we not only bonded with the host nation folks, but we bonded amongst each other. I've worked here at the 433rd coming on 2 years now, but I've met all tons of amazing people now that I have that much of a closer connection. Talk about people from within the unit that you now know better thanks to LAMAT.
I think that is a unique aspect to the military, is that that's what brings you together, and that what makes it a very strong bond is sharing these experiences, difficult and good, being in the same situation together, being in the same struggle together, and then also enjoying the good times together. And I think going into this mission and going into these experiences, whether it's a deployment, whether it's an annual tour, it does bring everyone together, and it does solidify that sense of camaraderie. I think coming home from something like this, really you come home much closer to your coworkers, to much closer to your wingmen and to your fellow unit members. And I think that over time kind of grows in a very unique way that you cannot get anywhere else.
Yeah, the timing couldn't have been better for our units, in particular the medical squadron, who is in the process of conversion. They went from an Air Force theater hospital to an EMEDS unit that has ground surgical teams and CCAT teams. And the process of doing that, though, involved a massive churn of personnel, creating a large number of new UTCs, a huge number of new people walking in the door, and all of a sudden you bring all those people together, some that have been here for a long time, some that are new, some in the middle, and bring them together on a common mission and send them to go accomplish it for a couple of weeks. Like I say, the timing couldn't have been better.
Absolutely. We could probably be here for quite some time discussing all the amazing things of LAMAT, but I always like to close these conversations by opening it up to anything that's still on y'all's minds about this LAMAT or hopefully the LAMATs of the future.
Oh, I got all kinds of stuff. We're not close to done. No. So one thing that there was a million lessons learned from this. And one of those lessons that I keep thinking about, this is one that I ponder more than any other, is what does it really mean to be ready? Because we treated this from start to finish as a deployment. We looked at the needs in reference to a TIBFID that you would do at a bigger level. We started assembling that team. We had to crowdsource when we couldn't fill AFSCs. We built sub-teams around the providers that were going. And then we looked at, okay, what do we need to do to actually get people out the door? And there were a few things that really rose to the top. The ability to get out the door lies almost entirely on the backs of our administrative personnel. They get a lot of static because when things go wrong, we blame them. But when it comes down to getting out the door, our administrative team rose above and beyond, from generating orders and travel to making sure people had passports and country clearances and all the different things that were involved in getting there. We discovered 100 things that we don't do well. And we started picking them off one by one. And we learned a whole lot about what it actually takes to generate and deploy these medical teams across 4 different countries. What does it really look like to be ready? It means to the individual airman, you need to have your stuff buttoned down. You need to make sure that you have a passport, that you have a current GTC, that you have a good communication plan and a family plan, both within your unit and without. You need to be fit. It is physically hard to go work in an austere environment, even if you're doing nothing more than providing medical care, which you don't think is physically taxing. Ask somebody at the end of a 14-hour day in a hot building, how exhausted they were by the end of that day. Fitness is huge. So those are some of the things that really struck me as what it looks like to have a ready medical troop. I found unpopular opinion. I don't think that medical readiness really equates very well to mission readiness. Some of the most effective combat teams I've encountered over the years are made up of a few old guys who are doing their best just to hold themselves together, but they bring a wealth of knowledge and experience to that team. Then you've got some young lions who are out there training themselves so hard that they're constantly in some state of being broke. So they aren't medically ready either, but you combine those two together, and as a medical side, our responsibility is to maximize their ability to participate in that mission. We did a little of that on this. We pushed the medical waiver authority to the team commander, to that squadron commander, and let them make the call on whether this person was medically fit to go do this mission. We had 0 issues. We had some people that we had to do some local waivers for to get them down there. Every single one performed at a high level. So that was very encouraging to me that we can work around some of this stuff. What lessons do you have in Major Rod?
No, sir, I can't say it any better. I think just the adapt and overcome culture. That is always something that, as a military service member and a medical professional should be forefront of our thought process. We should not accept roadblocks, whether it's during treating a patient, working up a diagnosis, taking care of a very critically ill patient, or accomplishing a mission, trying to make sure, all right, what is the problem, how to work the problem, and how to overcome the problem. There's always a solution, you just haven't thought of it yet. And then leaning on your fellow service members, your wingmen, that is paramount. The leadership from the squadron level, med group level, MAJCOM level was outstanding. And I think that was, to me, one of the unique aspects of it, is pushing down the decision responsibility to where, all right, you're going to do this mission. This is what you're supposed to do. Figure out how to do it. When it comes to from the level of a senior airman to the level of an officer to the higher up leadership, that is the same concept of what is the problem, how to overcome it, how to accomplish the mission, and being agile and being able to adapt to any environment, I think, is the unique lesson that I learned. How do you bring the best care, the best performance to any situation?
From my experience, I saw nothing but tenacity from the service members that I was working alongside and documenting their work, not accepting roadblocks, being innovative, having a good attitude, which is like an amazing part of the equation, right? It was really impressive. And as PA, it's always nice to be covering members who have that mindset, because it just facilitates the whole process. It just all flows so much more naturally when everyone's clicking on the same page, happy to be there, pushing forward for a good outcome.
Oh, yeah. You mentioned watching people lead. I'm just going to throw a few names out there. You go somewhere and say, hey, who's taking care of this? And you say, oh, that's Tech Sergeant Ruddle. And oh, who's got this? Oh, Lieutenant McMurray's got that. It wasn't colonels and chiefs that were leading things down there, that were taking on parts of this mission and making it happen. It was NCOs. It was CGOs. We are so rank heavy in the medical side that people don't get a chance to lead much at the more junior ranks. And given the opportunity, they jumped all over it. And so that's another great lesson for us, is give people the opportunity to lead, and they're going to make you proud.
Absolutely. Gentlemen, we could be here all afternoon, but I want to be respectful of your time. So thank you so much for making time to have this discussion. And I think we have a closing thought.
Yeah, 21 years. So we have a airman who has been in the 433rd Medical Group for 21 years. In that time, they have never done an off-station annual tour. Every time annual tour rolls around, they go to either one of their required classes, or they come in and work on medical cases or admin processes. Given the opportunity, they were so grateful to AFSouth and their team for letting them be a part of this. And that airman is now walking tall and generating a level of esprit de corps and retention that you can't get anywhere else. We planned this for 8 months. We executed it for 8 weeks. We did 15,000 plus AFSC specific critical pre-deployment tasks across 40 AFSCs. We integrated with our active duty National Guard, Army, Coast Guard, Navy, Department of State, and embassy teams. And at the end of the day, we got more training value and more hands-on real-world deployment experience that you can get from any exercise. Okay, you can't simulate this stuff. You can't inject the number of variables into this stuff, and there's no alibis, and oftentimes there's no second chance if you get it wrong. So in my mind, readiness doesn't get any more real than that.
Couldn't have said it better myself. And for anyone out there in the audience who wants more LAMAT in their life, there is no shortage of good coverage on the 433rd Airlift Wing website. If you just Google 433rd Airlift Wing, it'll pop up. We took so many photos, put together some videos, and tried to share as many of the stories of the members who were down there working. Gentlemen, thanks again for making time to talk a little bit of LAMAT today with me.
Julian, I thought we were doing long form here. Come on now.
Thank you very much.
Appreciate your time.
For this coming UTA's announcements, please check out our monthly Alamo flyer that is sent out via email and posted on the AF Connect app. That's going to do it for this episode of Ready, Set, Airlift. I've been your host, Julian Hernandez. Thanks for spending some time with us. Until next time, take care.